Good morning, good afternoon, good evening. Welcome to our global grand rounds for the Academy of American Academy of Otolaryngology Hand Neck Surgery. My name is Maria Serna, and I'm the coordinator for international affairs for American Academy of Otolaryngology and Head and Neck Surgery. So today's global grand rounds are on multi-level surgical approach to sleep apnea management. And as always, we have a lot of attendees from 121 countries who signed up for this global grand rounds. And if you'd like to share which countries you're from in the chat, that would be wonderful. This way we can actually see who is here, who is participating, and welcome. Today's Global Grand Rounds is sponsored by Inspire. Inspire is the company that introduced hypoglossal nerve stimulation for treatment of obstructive sleep apnea and innovation in our field. So thank you so much for the sponsorship and support of our field. This is our brief overview of the program. I'll start with some of the introductions. So Dr. Brown, he is our president of the American Academy. And Dr. Brown, please give your remarks on behalf of the Academy.
Good morning. What an amazing way to start this day with so many otolaryngologists from around the world in the same Zoom room. This is powerful and so healthy for the specialty of otolaryngology worldwide. I am Gene Brown, and I practice general otolaryngology in Charleston, South Carolina. I'm the current president of the American Academy of Otolaryngology Head and Neck Surgery. And on the behalf of the Academy, it's a great honor to be with you this morning and to welcome you to Global Grand Rounds. I had a great time meeting some of you in Santiago at the Pan American meeting earlier this month, and I look forward to meeting many others of you as I travel to other international meetings in the upcoming year. Please come up and introduce yourselves. I'd like to meet you and hear about your practices, your challenges, and how otolaryngology is delivered in your countries. Global Grand Rounds is an outreach that reflects our commitment to the specialty and to education around the world so that inevitably all of us can deliver the best care to patients. Thank you for giving of your weekend time to spend here with us today, and I hope that the knowledge shared and gained is impactful for patients around the world. I hope the program is great, and thanks for having me along.
Thank you, Dr. Brown, and thank you for supporting and joining the Global Grand Rounds. Next, I would like to introduce Dr. Rahul Shah, who is our Executive Vice President and CEO of the American Academy of Otolaryngology and Head and Neck Surgery. Dr. Shah.
Welcome, everybody. This is certainly the highlight for me 4 times a year when we come together. Take a moment and look at the chat. I won't be offended if you ignore me. Look where our colleagues are from, all over the world. I've seen Lebanon, Latvia, India, Nepal, Mongolia. I can name them. It is so amazing. This is really the global community and the largest voice we have. I'm in awe of that. Much gratitude to the Indian Association of Otolaryngology Head and Neck Surgery for sponsoring and being part of our team this morning. It's wonderful. Thank you to the International Surgical Sleep Society. We've entered into a partnership with them for over a year, where together we work to amplify the voice of international sleep. And of course, to our corporate champion, Inspire, much gratitude for making this available, recording it, and helping invest in our academy. Our strategic plan has 2 pillars. We want to modernize our academy and unify our specialty. And Dr. Brown, my view, and the board, there's no bigger message than coming together globally to unify the voice of otolaryngology. We've learned that together we stand strong. Dr. Brown and myself look forward to seeing all of you in October next year in Los Angeles. Onwards, and much gratitude.
Thank you, Dr. Shah. So next, as was mentioned, these Global Grand Rounds are co-sponsored with International Surgical Sleep Society. And Dr. Srinivas Kishore Sisla is one of the international board members of the International Surgical Sleep Society, and he is the co-chair for the upcoming meeting, International Surgical Sleep Society meeting in Mumbai. And Dr. Kishore Sisla will share some comments about that.
Uh, Thank you, Maria. I'm going to share my slides now. Can you see my slide deck?
Yes.
Good morning, good afternoon, and good evening, based on where you're from. My name is Srinivas Kishore Sisla, and I'm here to introduce an upcoming meeting, which is very relevant to our specialty. And we know based on the sheer number of registrants who have basically registered for this event. And it's very relevant now that sleep apnea and management of obstructive sleep apnea has become absolutely pivotal in for especially for the otolaryngologist of today. So from the 20th to 22nd of February 2026, we at the Indian Association of Surgeons for Sleep Apnea, along with the International Surgical Sleep Society, are very proud to host the 14th annual meeting of the ISSS and the 12th annual meeting of the IASSA. Now, theme is of this meeting is a worldwide wisdom in sleep surgery, and it's going to be a truly global conference primarily because we have over 100 distinguished international and national faculty. And the highlights of this meeting are 6 orations, we have 150 guest lectures, 15 panel discussions spread across specialties, 15 dedicated symposia, 15 instructional courses on certain topics, which will include a lot of handholding. Very interestingly, we also have 15 surgical sessions, which we also call as How I Do It sessions. We have 10 debates on kind of topics which are very debatable. We have a very interesting quiz in addition to the award papers and poster presentations. So if you're somebody who's interested in the management of obstructive sleep apnea, both surgical and non-surgical, this is a meeting that you should be at. Please, this is from the 20th to 22nd of February in the vibrant city of Mumbai. Here is the link for you if you want to take a picture of it. All the details of the meeting are there in our website. The abstracts can be also submitted. The deadline is December 31st. You can also register from the website. And thank you very much for this opportunity, American Academy, and also Maria. Thank you very much.
Thank you. Thank you for the introduction. It sounds like it's going to be a very exciting meeting. I'm looking forward to attending it. And again, thank you so much for the introduction. And moving on, we have Dr. Vijay Krishnan, who is Secretary of Indian Academy of Otolaryngology and Head and Neck Surgery. Dr. Krishnan, please.
Good day to everyone who have joined us across the world. It is a pleasure to welcome you all to this Global Grand Rounds webinar hosted by American Academy. I'm honored to serve as a co-moderator on behalf of Indian Academy of OTO-HNS Head and Neck Surgery. The AAO-HNS is one of the largest ENT organizations in India, representing thousands of academicians and otolaryngologists across the country. It was founded by some of the most distinguished leaders who is who in our field and continues to uphold a strong legacy of advancing ENT in our country. It was founded by the group of people who are really interested to do a clinical excellence in surgical innovation, education, and international collaboration through national conferences, structured training programs, fellowships, and academic partnerships with global societies, AAO-HNS remains committed to elevating ENT practice and fostering meaningful professional engagement. We have also recently launched the Young AAO-HNS initiative to empower early career ENT surgeons through dedicated training, mentorship programs, and leadership development. We are delighted to be associated with today's session alongside the International Surgical Sleep Society and American Academy. So programs like this truly strengthens our global sleep surgery community, enabling us to exchange knowledge, address ongoing challenges, and work together to improve patient care worldwide. So thank you all for joining with us. Let us move ahead.
Thank you so much. So now I would like to introduce our panelist, Dr. Megan Durr, who is an expert in sleep surgery. She's from University of California in San Francisco, and she also is the chair of Women Otolaryngology at the American Academy of Otolaryngology Head and Neck Surgery. Also, Dr. Vijaya Krishnan, who just gave a wonderful overview of the Indian Academy of Otolaryngology, and he's also expert in sleep surgery. He's been, again, world renowned in the field. And Dr. Durr and Dr. Krishnan, please.
Thank you, Maria. Do you want to swap display settings, make it a little bigger? I'm Megan Durr. Thank you, Maria, for the introduction. I'm from University of California, San Francisco, and I'm so happy to be moderating this with my co-moderator, Dr. Krishnan. So the way the sessions will go, we have 4 expert speakers that will come up on this slide. They will each give a presentation on their specific topic, and then we will have a Q&A session, hopefully around 15 minutes for Q&A at the end. So just so everyone in the audience knows, there's the chat, which we've been using, and I love seeing where you all are from. There is also a Q&A button at the bottom. If you specifically have a question for a panelist that you want answered, put it in Q&A just so we can keep those sorted out separately from the chat. We will do our best to answer them in real time, and we'll also hopefully be able to answer at least a few of them live at the end. So our presenters, first we have Olivier Vanderveken, who will be discussing prognostic factors in hypoglossal nerve stimulation. Then Sukhvinder Bindra, who will be discussing the role of skeletal surgeries in management of obstructive sleep apnea, followed by Dr. Agrawal, who will be discussing principles of palate surgery for OSA, and then Dr. Kirkham discussing management of complex and refractory pediatric OSA. So we'll go ahead and get started. I will let my co-moderator, Dr. Krishnan, introduce Dr. Vanderveken.
Yep. Nice topics, Percy. It's my pleasure to invite and introduce Professor Olivier Vanderveken from University of Antwerpen, Belgium, who is globally respected leader in sleep surgery, well known for his pioneering work in drug-induced sleep endoscopy and upper airway stimulation therapy. His research has shaped international guidelines and greatly influenced how we evaluate and look at the DISE and its finding. It is an honor to have him to share his expertise with us on prognostic factors on hypoglossal nerve stimulation. Does DISE and other phenotyping improve surgical outcome? Please, Professor Olivier.
Thank you so much for that kind introduction and the invitation to be one of the speakers here today at the Global Grand Round. So today I will indeed have the topic of prognostic factors in hypoglossal nerve stimulation with the question, does DISE and other phenoendotyping improve surgical outcome? So these are some potential conflicts of interest that need to be disclosed. And then I wanted to point out that the attempt should be to move on also in sleep surgery to a more personalized medicine. And therefore we can use the concept of phenoendotyping. And there, the endotype is a subtype of a condition that has a distinct functional or pathobiological mechanism. And for the condition of obstructive sleep apnea, it might also refer to the pathophysiology of obstructive sleep apnea. And then we can move on to the phenotype. That would be the observable consequence of the disease. And this could help us to deliver a more personalized or more precision-based sleep medicine. And fortunately, in our routine daily practice, we are already using some of the layers of this OSA endotyping. We are using to look at risk factors and environment in terms of, for instance, obesity, medication, alcohol usage. We are looking at clinical features, the age of the patient, the severity of the obstructive sleep apnea. But a question turns up when we talk about pathophysiology. I will elaborate on the fact that site and pattern of upper airway collapse might be documented indeed by our clinical standard, such as drug-induced sleep endoscopy. But the data on degree of collapsibility of the upper airway, muscle responsiveness, the degree of ventilatory stability, and the arousal threshold are not readily available in our clinics. However, it could be important to understand this much better in the individual patient, because we all know that an OSA patient compared to a matched control will have a more narrow upper airway, and that impaired upper airway anatomy is a prerequisite in every OSA patient, but impairment in the so-called non-anatomical threats, such as low respiratory arousal threshold, poor pharyngeal muscle responsiveness, and high loop gain, could also importantly contribute to the OSA pathogenesis for the majority of our patients, but with a large inter-individual variability. And so that's how we at our lab look at those key elements in the pathogenesis of OSA. First of all, there's the anatomy with the site and pattern and degree of upper airway collapse. There's also the degree of upper airway collapsibility, but then come in the other pathophysiological threats, such as the degree of ventilatory control stability, the degree of pharyngeal muscle responsiveness, and the arousal threshold. And so if you want to understand that better, we should have some definition. And so here are some definitions of what could be the markers of the pathophysiological threats. We could use critical closing pressure, or PCRIT, as a marker of the degree of upper airway collapsibility, defined as a propensity for the upper airway to collapse. And the higher this value, the higher the collapsibility within the collapsible segment of the upper airway of the patient. Secondly, there's a degree of ventilatory control stability, where loop gain could be our marker, defined as a degree of ventilatory instability or stability, with a higher loop gain referring to a less stable ventilatory control system. Pharyngeal muscle responsiveness has the marker of compensation, which is defined as the ability to recruit upper airway muscles when flow decreases. And the higher this pharyngeal muscle responsiveness, the more able patient will be to compensate for longer events. Last but not least is the arousal threshold as a marker of the propensity to wake up. The lower a patient's arousal threshold, the more easily he or she will be woken up by any trigger. And within the data of the START trial, we could do an analysis and checking which of these pathophysiological threats could be predictive with regards to the treatment outcome of hypoglossal nerve stimulation. And out of the analysis, it turned out that the arousal threshold was the most important parameter for the prediction. With a high arousal threshold, again, patients that are less easily woken up from a trigger are doing better. So this is a favorable predictor, probably referring to an increased tolerability for the upper airway stimulation in these patients. A second parameter was a low loop gain, being a favorable predictor, which is very similar to the treatment outcome of oral appliance therapy and our classical upper airway surgery. And the last factor was a high muscle responsiveness. And probably this is a favorable predictor because in this case of hypoglossal nerve stimulation, this could mean that in that patient group, the genioglossus dilator muscle apparatus is functional and can be activated by the treatment. But of course, larger prospective studies are needed to confirm these results. And then moving back to the anatomical threats in terms of deciding on the site, pattern, and degree of upper airway collapse. Gold standard for that assessment would be natural sleep endoscopy, but is not realistic in our routine setting because it requires overnight endoscopy during polysomnography with one medical doctor and one nurse per patient. So it's much too labor intensive and time consuming. And fortunately, over the years, we got this clinical standard being drug-induced sleep endoscopy that can be used in the routine. And in the early days already of the hypoglossal nerve stimulation therapy, there was this very specific DICE phenoendotype, complete concentric collapse at the palate, abbreviated as the CCC pattern, where it turned out that these patients were no good candidates for the therapy. And so here is the video depicted of that CCC DICE phenoendotype. But on the other hand, that patient that would not have CCC, but have like a partial palatal collapse or a complete anteroposterior collapse at the level of the palate are good candidates for the therapy with hypoglossal nerve stimulation. And then over the more recent years, it turned out that the role for drug-induced sleep endoscopy in counseling candidates for hypoglossal nerve stimulation extends beyond solely for excluding CCC, as it was demonstrated that oropharyngeal lateral wall collapse, and more in particular, a complete lateral collapse at the level of the oropharynx, which, by the way, frequently occurs concurrently with CCC, has been found to negatively impact therapy response for hypoglossal nerve stimulation as well as for oral appliance therapy. And that, on the other hand, when a patient would have a partial or a complete tongue-based collapse during the baseline DICE, that this would be a favorable predictor towards a good treatment outcome with this therapy. In other words, when performing DICE, probably we need to exclude patients with CCC and oropharyngeal lateral wall collapse and include patients that have a tongue-based collapse. But then a key question would be, do we need that DICE in all of these patients, or are we able to make a distinction between all those DICE phenoendotypes, which are patterns of collapse in the collapsible segment of the upper airway based on the flow signal of the sleep study? And so here are some representative examples of airflow shapes that were recorded during DICE. And at the upper part of the slide is a typical example of oropharyngeal lateral wall collapse. And on the bottom of the slide, a typical example of tongue-based collapse. And so looking at the above example, in particular in the middle image, we see this very typical complete oropharyngeal lateral wall collapse on the endoscopy. And the corresponding airflow tracing recorded during DICE displays a within breath decline in inspiratory flow consistent with a high negative effort dependence. And looking at the signal, and this is depicted here, you can see that there is a true scoopiness of the flow signal, which is reflective of a compliant, dynamically collapsing airway. And this is very different from the example that is here on the bottom of the slide, where we are looking at a tongue-based collapse, and the inspiratory flow tracing is much more flattening. And we call it like a flat-topped inspiratory flow contour that is consistent with a fixed airflow limitation without any progressive collapse as compared to the oropharyngeal lateral wall collapse. And so the figure that is here, 0.94 on the upper panel and 0.12 at the lower panel, is the corresponding probability that we can calculate with a mathematical model of the probability for oropharyngeal lateral wall collapse. And as you can see in that example of tongue-based collapse, that probability calculated by the model is very low. And so here are then other examples from other patients where you can see that this model can predict it quite good with a probability between 0.93 and 0.98 for oropharyngeal lateral wall collapse when there's this scoopiness on the flow pattern, and on the other hand, in tongue-based collapse with a very low probability for oropharyngeal lateral wall collapse between 0.11 and 0.24. And so when calculating that probability, we notice that patients with a low probability for oropharyngeal lateral wall collapse have a much higher probability to be successfully treated with hypoglossal nerve stimulation therapy, even if we're not doing the DISE, but only using the airflow signal from a home sleep test. So as a take-home message and conclusion, high arousal threshold and high muscle responsiveness, and also a low loop gain, should be further investigated as important non-anatomical predictors of a good outcome with hypoglossal nerve stimulation. And these parameters should become readily available in routine for prospective upfront selection of the right candidates for this therapy. The role for DISE in counseling candidates for hypoglossal nerve stimulation extends beyond solely for excluding CCC related to the velum, as complete oropharyngeal lateral wall collapse is an adverse predictor too. Further validation of the oropharyngeal lateral wall collapse as a key predictor of the success or non-success with hypoglossal nerve stimulation includes the potential of a novel, non-invasive airflow-based modeling derived from routine sleep studies, providing a scalable gateway to better understand upper airway dynamics during sleep for therapy selection. And with that, I would like to thank you for your attention.
Thank you very much, Professor Olivier, for that short, crispy, and comprehensive presentation. So we will now move on to the discussion. I invite all attendees to please post your questions in the Q&A box, and we will address as many possible during the session. And I would request Megan to introduce the next speaker, and we'll move on to the next talk.
Great. Thank you for that wonderful talk, Dr. Vanderveken. Next up, we have Dr. Sukhvinder Bindra, who'll be discussing maxillomandibular advancement. Dr. Bindra is an accomplished oral and maxillofacial surgeon with over 2 decades of clinical, academic, and surgical experience. She's a postgraduate from the Postgraduate Institute of Medical Sciences. She holds the distinction of being the 3rd female maxillofacial surgeon in Telangana. She currently heads the dental and maxillofacial surgery teams at Apollo Hospital and Shenoy hospitals in Sukhvinder, India, where she has established a robust multidisciplinary program for the surgical management of OSA in collaboration with otolaryngologists, orthodontists, and pediatric dentists. Welcome, Dr. Bindra. Thank you for presenting.
Good day, everyone. I'm trying to share my slides. Are you able to see the slide?
We can see if you just put in slideshow, I think we'll be good.
Sure.
That looks great.
Good day, I'm Dr. Sukhvinder Bindra, oral and maxillofacial surgeons. Namaste. And today I'll be discussing about role of skeletal surgeries in management of obstructive sleep apnea. So let's have a look at how craniomaxillofacial skeletal growth is associated with breathing pattern. As human beings, we are designed to breathe through the nose, but due to any obstruction in nasal breathing, when the breathing pattern changes to mouth breathing, and this is how the growth gets affected, both the upper and lower jaw, they start growing downward and backward, which results in retruded jaws and narrow airway. This not only affects the anterior-posterior dimension, but it also affects the transverse dimension of the upper jaw. So I request my ENT colleagues here, when you look at the patient, just look up towards the palate. Do you see a nice U-shaped wide maxilla or wide palate, or are you seeing at V-shape, narrow maxilla, high arched palate, and the crowding of teeth? If you see this picture, this is transverse maxillary deficiency, and this needs addressing. So as ENT surgeons, you people deal with the contents like turbinates, adenoids, etc. And we as maxillofacial surgeons deal with the container or the bony box, which is maxilla and mandible. And we try to enlarge this bony box or the container to appropriately fit the contents or the soft tissues. The previous old Stanford protocol was to advocate maxillomandibular osteotomies in case the soft tissue surgeries used to fail. But there is a shift in paradigm over the years, and now the latest Stanford protocol advocates maxillomandibular advancement and DOM, which is distraction osteogenesis maxillary expansion procedure, as first choice if a patient has complete concentric collapse, lateral pharyngeal wall collapse, and dentofacial deformity. So these deformities are in two dimensions. One is anterior-posterior and the other is transverse deficiency. So in transverse deficiency, you will appreciate narrow maxilla, high arched palate, narrow mandible in terms of width. And in anterior-posterior deficiency, there will be hypoplastic maxilla, retrognathic mandible, and short chin. And how do we address them? So if it is a narrow maxilla, we widen it by expanding it using different expansion protocols. And if it is a anterior-posterior deficiency, we do maxillomandibular advancement in which we bring the maxilla and mandible forward. And if you need to address the short chin or genioglossus muscle, then we have genioplasty and genioglossus advancement available. The relationship of nose and nasal and maxillary bone is very, very pivotal. 50% of the nose is formed by the maxillary bone. And imagine if this bone is narrow, what will happen? It will reduce the transverse dimension of nasal cavity. It will increase the nasal airway resistance, reduce lateral dimension of pharyngeal airway, and all of this will make the patient more prone to collapse during sleep and contribute to obstructive sleep apnea. So now I just request all the participants over there to check where your tongue is resting in the mouth. Ideally, the tongue should rest in the anterior part of palate, but if the maxilla is narrow, it won't rest there. So where does it go? It goes into the floor of the mouth and it will block the retrolingual airway. So how do we advance or how do we widen the maxilla? We use the basic principle that the roof of the mouth is floor of the nose. So if I widen the maxillary roof or if I widen the roof of the mouth, I will be indirectly widening the floor of the nose also. And that's how we increase the volume of nasal cavity. This is a skeletal expander device which we anchor on the teeth. It is a tooth bone device. And we give the Leaford 1 osteotomy cuts, which is similar to Leaford 1 fractures. We can give a mid-palatine cut, which may or may not be necessary. And the key given to this expansion screw will start drifting the two maxillary apart and they will start widening. Once we have achieved enough expansion, we give a consolidation period. And after that, we align the teeth with orthodontics so that the patient is able to chew properly. And this is how the surgical assisted rapid maxillary expansion works. There is another procedure which is DOM or distraction osteogenesis maxillary expansion. The cuts are same of osteotomy, but the difference is anchoring. In this, the anchoring is on the bone. The Sarme device was taking anchorage on the tooth. So these are the two differences. And there is enough data out in literature to substantiate that maxillary expansion techniques have been shown to increase the upper airway volume and improve breathing. And 9.7 to 12.9% volume can be gained by using surgically assisted rapid maxillary expansion or SARMI. So when you do maxillary expansion, it helps in lowering down the palatal vault, which was very high arch. So when the palatal vault becomes shallow, the tongue also starts resting in the proper position, which help in increasing the air passage through the retrolingual airway. So now imagine yourself wearing a narrow shoe. Will you be able to slide your foot forward? I don't think so. If I widen the shoe a bit, you will be able to slide your foot forward. So this is the same principle which is holding true for maxilla and mandible relationship. Here the shoe is maxilla and foot is the mandible. So when you unlock the maxilla, when you open the maxilla, the lower jaw comes forward. So even 3 millimeter mandibular advancement will give you a volume gain of approximately 3 into 3 into 3, which is 27 millimeter cube. So that is another advantage. And maxillary expansion has been shown by many authors that it improves the sleep parameters. Whether it is SARMI or DOM procedure, both of them are effective. So who are the candidates who will benefit from this procedure? Patients who have transverse maxillary deficiency, narrow maxilla, who have high-arched palate. Sometimes the whole midface is deficient. Sometimes the patient are non-compliant to CPAP because the mask is not fitting on the short jaws. And the pediatric patients who have craniofacial abnormalities where there is craniosynostosis. And these are the procedures available to use to widen the maxilla. So now I will be taking you through few cases which have been treated by us. So this is a 43-year-old female or a patient with obstructive sleep apnea who was treated with DOM along with the ENT surgery as a multi-level surgical approach. So we have given the DOM device, and this is how she was after 1.5 years. And this is how her jaw looked like after 1.5 years of completion of the treatment. And when we did her sleep study, her AHI index also have been remarkably reduced from 32 to 3. DOM device gives us a beautiful parallel expansion from anterior nasal spine to posterior nasal spine. And this is how we do the airway volume analysis, taking a CBCT scan in 3 dimensions. Another case who was treated as a part of multi-level surgery where adenotonsillectomy, turbinoplasty, septoplasty was done, and we have done the SARMI, and this is the SARMI device inserted immediately after surgery. And this is how she has undergone the complete treatment where we have expanded the maxilla. After that, we started the orthodontic treatment. And this is how the patient is after 4 years, and her snoring and speech difficulties have been taken care. Another case where 32-year-old male patient has been treated by SARMI, and this is how the patient is after 2.5 years of follow-up. A treated cleft palate case was also addressed by SARMI because of snoring, and he was not able to breathe properly. If you see this picture, pre-operative, you can hardly appreciate any maxillary teeth. So maxilla was totally contained in the mandible, and this is how we have done the surgical expansion and how he is after 3.5 years of treatment. You can appreciate the maxilla not only has widened, but it has come forward to take care of the airway problems. Another tool in our armamentarium is maxillomandibular advancement, where we do the Leaford 1 osteotomy to bring the maxilla forward. We do bilateral sagittal split osteotomy to bring the mandible forward. And along with that, you can combine the genioglossus advancement or genioplasty. So in this video, you will be able to appreciate how, this is the constricted airway, and that was the ideal airway. So this is the pre-surgical orthodontics, which may not be needed for every patient. These are the 2 bilateral sagittal osteotomy cuts, and this is the Leaford 1 osteotomy cut. Together, the maxilla and mandible are brought forward, and they are fixed in the desired position. And this is how the airway improves after maxillomandibular advancement. This is the constricted, and this is after MMA. This is how the airway should be. So candidates who will benefit from maxillomandibular advancement are the ones who have moderate to severe obstructive sleep apnea with a dentofacial deformity, which is hypoplastic maxilla, retrognathic mandible, or short chin. And sometimes when there is inadequate improvement with the soft tissue, or few patients who are really inclined for a permanent single stage surgical solution. So the pre-surgical workup is assessment of the patient, airway imaging, counseling, informed consent, lateral cephalogram, and CBCT analysis guide us to how much we can advance and how the airway is going to improve. We take the profile pictures of the patient. The CT scan is sent for virtual surgical planning, where we plan how much maxilla and mandible will be advanced and how we can rotate it for our maximum benefit, and at the same time not compromising on the aesthetics of the patient. So the surgical procedures are Lefort 1 osteotomy, bilateral sagittal split osteotomy, and genioplasty. Due to paucity of time, I am not going into the details of surgery. So these are the few patients who have been really benefited by maxillomandibular advancement procedures. And how does it help? If you advance the maxilla and mandible for about 8 to 10 millimeter, it increases airway in all the 3 dimensions. Maxillary advancement increases velopharyngeal space. It increases the tension of pharyngeal soft tissue and reduces the collapsibility. And when you bring the mandible forward, along with genioglossus muscle, other suprahyoid muscles are also brought forward, which really help pull the tongue upward, forward, and away from pharynx, which helps the patient a lot. And it has been shown in literature that it is an effective tool in management of sleep apnea, and it is preferred for its high success rate, long-term permanent solution, and it improves the airway at multiple levels. Advancement genioplasty is a versatile procedure. You can be combining it as a multi-level surgery along with ENT surgeons, or you can do it along with MMA. You can combine it as a multi-level, multi-stage surgery where you address the soft tissue first and probably address the hard tissue later. And
surgeons can
this is
sliding genioplasty.
the sliding genioplasty is performed
8, 10 or 12 minutes.
and
Projection.
this is the final outcome. And this is how we do it in the OT. And this is the pre and post-op picture of a patient who has undergone multi-level surgery where nose, palate, and genioplasty was done in the same sitting under same anesthesia. So in the last, I would like to convey the message that obstructive sleep apnea is a structural disorder which involves both soft tissues and skeletal component. The debate is not whether we should address bony box or we address the soft tissue, but it should be a structured, phenotypic presentation and scientific protocol to decide what to treat first. If there is a soft tissue hypertrophy which is dominating, we should address that first. But if there is a craniomaxillofacial skeletal problem, we should address that first. So soft tissue opens the airway, bone keeps it open, and collaboration keeps it stable. And I would like to thank for your patient listening by saying that OSA surgery works best not by cutting more, but by rebuilding better. When ENT and maxillofacial surgeons unite, function aligns with structure, and patients finally breathe better. Thank you so much for your kind attention.
Thank you so much, Bindra. That was a wonderful presentation. I love the foot and shoe analogy. I think I will use that myself in the future. Appreciate it. You have some questions in Q&A if you don't mind addressing those now that you're done.
Yeah.
And Dr. Krishnan will introduce our next speaker, Dr. Agrawal. I think you're on mute, Dr. Krishnan.
It is my great privilege to introduce our next distinguished speaker, Dr. Vikas Agrawal from Mumbai, India. Dr. Agrawal is an eminent ENT sleep surgeon known for his extensive experience in soft tissue and multi-level surgery. He practices at the Specialty ENT Hospital in Mumbai and has contributed significantly to advance surgical management of sleep apnea in India. His expertise spans DICE-guided surgery, palatal and tongue-based procedures, and to introduce suspension, bridge pharyngoplasty, etc. So we are delighted to have him with us today. Please, Dr. Vikas.
Yeah. So thank you, Vijay. Thanks for the nice introduction. At the outset, my sincere thanks to the American Academy and ISSS to have me here. Let me share my screen. Are you able to see my screen?
Yes.
All right. So my topic for today is anatomy of palatal obstruction in OSA. So how palatal obstruction, what is the mechanism of palatal obstruction? So if you look at this video, the DICE video, and we see how the palate is collapsing. Now, if we take this last part backwards, you can see when the person is having snoring and sleep apnea, what is happening here, that the base of the uvula is going towards the posterior pharyngeal wall and touching here. You can see the tonsil here. This is the lower pole of the tonsil and this is the upper pole of the tonsil. So the upper pole of the tonsil is moving medially and backwards because you are seeing it from the superior aspect. So this is the movement you are able to see. So we try to recreate this understanding in form of animation. So I'm presenting it to you the series of animations that we created based on this observation. So when we look at the soft palate from the front, this is the upper pole of the tonsil, lower pole of the tonsil, uvula, anterior pillar, posterior pillar. Right? So when snoring happens, what happens? The superior pole of the tonsil goes medially and superiorly. Now, here we are seeing it from the front. So we are seeing the superior and the medial movements. But as we saw in the DICE video, so this is the movement happening from the superior, from the anterior aspect. But when we see it from the side view, as we saw in the DICE, the upper pole of the tonsils, they move posteriorly and go and touch the posterior pharyngeal wall. And when they go posteriorly, they push on the posterior pillar, which is the palatopharyngeus. And that's the area in question, which is causing obstructive sleep apnea in more than 95% of the patients. Obviously, patient can have a multi-level problem, can have nose block, can have tongue collapse, can have epiglottis, but the major part, almost 95% of the patients have at least a palatal collapse and then a combination of this. So this is the area which is responsible for snoring and sleep apnea. And if we understand how to deal with this area, then possibly we can treat sleep apnea much better. So as we understood that tonsils are the paramount structure which cause obstructive sleep apnea, but they have been classified based on their size only in one dimension. So tonsil grade 1, 2, 3, 4 is only, classified depending on what we see from the front. But tonsil is a three-dimensional structure. It has got 3 dimensions. We cannot classify it only on 1 dimension. So if we classify this tonsil only on the basis of the size of its tummy, because we are seeing it from this angle, it's not enough. We also need to understand the height and the width of the tonsil. So we also need to see what is the shoulder and what is the head. How much wide is the shoulder, because that will decide how much pressure the tonsil is putting at the back, and what is the height of the tonsil. So it's the upper pole of the tonsil, as I said earlier, which actually blocks. So when the tonsil increases in size, it also pushes the posterior pillar behind and reduces the retropalatal space. That means if you remove the tonsil, it will also increase the retrolingual space. So that is one more way the tonsillectomy is going to help this patient. Now, a large tonsil, which we call exophytic tonsil, only press in the middle. They do not really press at the back, and they are not so common. If an exophytic tonsil is pressing like this, and we have to see it in perspective, in a sleep endoscopy, it will look something like this. But there are not many sleep endoscopies that we get tonsils like this. Most of the tonsils are actually endophytic. They are hidden behind the pillars. So when they go and touch at the back, they actually push the posterior pillar behind. And as I showed earlier, that's the area where they actually create the problem. Most of the sleep endoscopies you would see, you can see the upper pole of the tonsil coming together. And this is the way they actually create obstruction. So endophytic tonsils equally can actually cause sleep apnea, whereas you might grade them as grade 1 or grade 2. But when you do the sleep endoscopy, they are really very, very important. Now coming to the muscles of the soft palate, there are 5 muscles in the soft palate. As the name suggests, the levator veli palatini or the levator palati muscle is the muscle which, let's understand the action of these muscles by animations, because this is the action of the tensor palati or the tensor belli palatini. As you can see, this is a quite anterior muscle and it makes the soft palate tense. It's a good muscle because it is not creating sleep apnea. It's only helping the patient to keep the soft palate tight. The next muscle, the most important, is the levator palati. As the name suggests, it elevates the soft palate. But as you can see, this is anterior to the area where the snoring and the sleep apnea was happening, which was this area, the soft palate, the upper pole of the tonsil pushing on the posterior pillar. So levator palati does not coincides with that area. And this is the understanding based on which we can perform all our surgeries, because the tensor and the levator do not come in the way of the area which actually causes snoring and sleep apnea. The third muscle, which is the anterior pillar or the palatoglossus. This is also a good muscle because, as you can see, it's only pulling the soft palate forwards, which is improving the retropalatal space. So this is a good muscle and we do not have to do anything to this muscle. The only muscle which causes problems by collapsing is the posterior pillar or the palatopharyngeus. And therefore, along with the upper pole of the tonsil, we need to take care of the palatopharyngeus. We might cut it, we might rotate it, we might do anything depending on the surgical technique that we use, we have to do to the palatopharyngeus. So the bottom line remains that we need to stay below the level of the levator and the tensor palati. The tensor palati is much anterior, levator is behind that, but still anterior to the level of the posterior pillar or the area where the sleep apnea happens. Palatoglossus, we need not interfere because it's a good muscle. Only the palatopharyngeus, especially the medial fibers of the palatopharyngeus, is what you need to take care. You might divide, you might rotate, you can do whatever, but this is the area. If you take care of these two muscles, levator and the tensor, and you do your surgery in the lower part, you will not give the patient velopharyngeal insufficiency, because as you see, the blue line is the area of the levator, and the snoring and the sleep apnea are much lower to that. So this is the most important understanding. Now, 90% of the palates are like a funnel. That means the upper part, which is the area of the levator and the tensor, it's really wide. It's not very narrow. And most of the blockage is in the lower part. So they are funnel-shaped palates. And you can do a proper surgery on them. As you saw here, it's looking like a funnel, lower part. Whereas, and you can see this on your CBCT, you can do the airway analysis and you can see this funnel. The upper part is broad and the lower part is narrow. You can very well see it on your CBCT most of the times. 5 to 10% of the soft palates are tunnel shaped. That means the upper and lower both are narrow, and that's where you have the difficulty, because you cannot perform surgery on the upper part of the soft palate because they contain the area of the levator and the tensor palati. And you can actually make out it on your cone beam CT, the sagittal CT. You can actually see in this patient, it's a vertical kind of a soft palate. So you will not be able to get a great result in this patient. And on the drug-induced sleep endoscopy, you see both upper and the lower part collapsing. So you have to be aware of this kind of soft palate. Other thing you have to remember is salpingopharyngeal fold. This was the discovery that we had around 2010 and 12. And in 2019, the classification of this salpingopharyngeal folds into grade 0, 1, and 2 was introduced by us in 2019. 23, this paper was actually, 2019 was this paper. And based on this, the suspension bridge pharyngoplasty model was, advocated. And this was the paper published around 2 years back. Now, if we look at this same area of sleep endoscopy from the superior view, which is the axial view, we understand that tonsils are on both sides of the uvula. You can see the palatoglossus and the palatopharyngeus. You can see the posterior pharyngeal wall. So the airway is narrow here, and the moment you remove the tonsils, the posterior pillar goes towards the anterior pillar. The palatopharyngeus goes towards the palatoglossus, and that enlarges the airway significantly. And the pterygomandibular raphe is located always anteriorly and laterally to the soft palate. And therefore, if you take a non-absorbable suture from pterygomandibular raphe across the midline from the right to the left and left to the right, then you can have a bridge which is suspended on the pterygomandibular raphe, and it will not let the median part of the soft palate collapse posteriorly. So the anteroposterior collapse is completely taken care of if you take this non-absorbable suture from right to left pterygomandibular raphe, and that will suspend the soft palate in the midline, and it will also not let the base of the tongue collapse because it will support the base of the tongue on itself. And for the lateral, this is suspension bridge is the name given, inspired by this Capilano suspension bridge in Canada. And if you want to take care of the lateral collapse as well, this is an old concept that from the pterygomandibular raphe, the lateral part is always hitched or suspended. So in one technique, you can take care of both anteroposterior and lateral collapse if you do the suspension bridge. Now, this patient is a minimally invasive surgery being shown. I'm only dividing the posterior pillar or the palatopharyngeus. The tonsil is not very large in this patient, and this patient is a mild obstructive sleep apnea patient. So if the tonsils are large, you will obviously remove the tonsil. But here in this case, the tonsil is absolutely not large, and it's only the fanning of the soft palate. So the posterior pillar is being divided by using ultra SP wand of coblation. And as you can see, the complete division towards the lateral side of the posterior pillar, you can see how much of space can be created. Same thing is being done on the other side. You can see the division of the oblique fibers of the palatopharyngeus. Why using coblation? Because that gives least amount of scarring, because we want least scarring on the soft palate. And you can open up the fibers. You can open up the bottleneck area very, very well using the ultra SP wand of the coblation. And as you can see here, the posterior pillar is divided. The oblique fibers of the palatopharyngeus are divided. Then length of the soft palate is more. So we have to reduce the length of the soft palate. Here, I'm not removing the uvula completely. I'm performing what is called uvulopalatopexy. So we have removed the mucosa on the oral aspect of the soft. Now this whole thing, and we are sticking the soft palate like this using bicual sutures. We have made the soft palate smaller by rotating the soft palate. Now this is the suspension bridge suture starting from mandibular raphe. You go across the midline. This is a non-absorbable barbed suture. Go across the midline. So this is to make sure that the soft palate does not collapse and cannot produce. Then from the midline to the pterygomandibular raphe on the left, this will draw the strength from the pterygomandibular raphe. And I'll take, and then you go back in the same way from left to right. So we use a 3O non-absorbable suture. Again, part across the midline, which will be exposed without exposing. Then I'll go to the right. That's across the right. Just to lock the suture. Take a. Now this is locked. Give me a scissor. So because it's a barbed suture, you do not need to take any stitches. So now what is the net effect of this surgery? These few vehicles will fall off in 20-25 days or a month's time. We have a lot of space already created at the back of the soft palate. This soft palate cannot collapse for snoring. But when the person is swallowing, then the levator palati is absolutely free to function. So that was the technique of suspension bridge pharyngoplasty. And if you understand the principles of the palatal surgery, you'll be able to do a much better job. And last but not the least, let me invite you once again as the program chair for this sleep surgery conference, the ISSS meeting in Mumbai. I welcome you all to Mumbai, my home city, and I hope we should be able to give you a good scientific program and a good, the gala. Mumbai is Bollywood, so we'll hopefully be able to give you good experience in the Bollywood, musical program as well. So thank you very much.
Thank you very much, Dr. Agrawal, for that detailed discussion and made us to understand the concept of palatal collapse. I would request all attendees to post your questions in the Q&A box. Next, we will move on to the next lecture. I would request Meghenda to introduce our next speaker. Thank you, Vikas, once again.
Great, thank you. I'm happy to introduce Dr. Erin Kirkham, who will be speaking on the surgical treatment of pediatric sleep apnea. She's a board-certified, fellowship-trained pediatric otolaryngologist at CS Mott Children's Hospital and an associate professor with tenure in the Department of Otolaryngology at the University of Michigan. Dr. Kirkham specializes in the management of complex and refractory pediatric sleep apnea. In addition, she co-directs a multidisciplinary pediatric refractory sleep apnea clinic in close collaboration with specialists in sleep medicine, oral and maxillofacial surgery, and orthodontics. Thank you, Dr. Kirkham.
Morning, everybody. Thank you so much, Maria, for organizing this and inviting me. And I've already learned a lot from everyone who's spoken before me. So as I think a lot of us know, OSA affects a lot of kids, about 6% of children, and it's about as common as asthma. And although many kids improve after first-line adenotonsillectomy, on average, 40% will have persistent OSA. And this can be up to 80% in high-risk populations with risk factors like obesity, Down syndrome, and hypotonia. And we have a big international audience here. So I recognize that there's certainly international variability in diagnostic access and treatment options. And we recognize there's still a need for evidence-based management algorithms for this condition that many of us see and treat in children. So luckily, I don't have to face the hard cases alone. At Mott, at University of Michigan, we have a dedicated multidisciplinary refractory OSA clinic. And I'm fortunate to work with an orthodontist, sleep medicine physicians, and oral maxillofacial surgeons to tackle the most challenging cases. Also, we now have an expert consensus statement to guide us from the Academy, and a set of guidelines put out by the American Thoracic Society that discuss the evidence for various options, which I will touch on. So when a child gets referred to our refractory OSA clinic for persistent OSA on a PSG, and the study shows mild OSA, generally that's defined as an AHI greater than 1 but less than 5, we screen them for symptoms. And you can do this clinically, of course, but simple one-page questionnaires like the Pediatric Sleep Questionnaire or the OSA 18 questionnaire are really helpful to try to quantify the symptoms and impact. And if the scores on those are below certain cutoffs, generally they're asymptomatic and observation is recommended. But if there's mild OSA that is persistently symptomatic, we do treat, and here's why. So our approach to treating symptoms in children with a low AHI really comes from what we learned recently from the PATS trial of adenotonsillectomy for children with mild sleep apnea. And what we found in this big randomized trial in the States is that treatment for mild symptomatic OSA, and I'd posit even persistent OSA after AT, may confer some benefit for kids. It may decrease the odds of progression to more severe OSA over time, and certainly may improve quality of life symptoms and behavior. So when a child has persistent OSA that's mild by AHI criteria, but still symptomatic, we start initially with medical management. And so treatments like topical nasal steroids or leukotriene modifiers like montelukast have been shown in trials to be effective in combination. Topical steroids alone are not so effective in treating OSA in randomized trials in kids. They offer improvements that are modest, and the long-term efficacy and safety is still unknown. There is a black box warning for montelukast in children, specifically listing some neuropsychiatric symptoms. So families are generally counseled to watch for any significant changes in mood, behavior, and discontinue immediately if these happen. So in obese children, who we see a lot, weight loss can be effective at reducing OSA, but a greater than 10% weight loss is generally required to reduce severe OSA. And of course, as with adults, compliance and long-term success is challenging, but there are some ongoing studies of GLP-1 agonists and other drugs in adolescents. Rapid maxillary expansion, which Dr. Bindra described in her talk, is indicated in children. Generally, they have to be over the age of 4 or so because they have to be cooperative with the device. These are kids who have a high arched palate and a posterior crossbite with occlusal problems. And studies show about 75% of children with mild to moderate OSA will experience an AHI reduction, but the resolution or cure rate is still pretty low. So this can improve, but doesn't necessarily resolve OSA. Medical therapies can be somewhat effective for moderate OSA, but are less effective for more severe OSA. So in a child whose persistent OSA is moderate or severe with an AHI over 5, generally we're thinking about other medical options, but recommending a PAP trial as a next step in these kids. And PAP can, of course, also be tried in mild symptomatic cases when medications, weight loss, or maxillary expansion aren't options or ineffective. So the main challenge with PAP in children is adherence. If we define adherence as using it for greater than 4 hours a night for over 70% of the nights, the adherence in children is about 46%. And but in our clinic, we do work on improving PAP adherence where we can, trying to optimize mask selection, using behavioral strategies. We consider high flow nasal cannula for kids that just absolutely can't tolerate the mask. And sometimes all I do as the surgeon in our clinic is describe the surgical alternatives to CPAP, which is, and if that's enough to get parents who are refusing PAP to actually try it, I consider that a win. But in many cases, non-surgical options, they just don't work. And then we consider DICE-assisted surgery in children. Sometimes I will do DICE alone, but much more frequently, parents prefer that we do DICE and surgery in the same setting. So in a first stage DICE, I'm usually prepared to do any combination of turbinate reduction, adenoid revision, expansion pharyngoplasty, lingual tonsillectomy, supraglottoplasty, epiglotopexy. And I find a wake scope in clinic can be helpful for planning for needing turbinate reduction, adenoids, or lingual tonsils, because those can be seen easily on a wake scope. I don't usually do tongue base reductions or advancements at that initial DICE-directed surgery, but I will save that as a second stage approach if needed, because those cases are more involved and higher risk and not indicated for every kid. So DICE is recommended in children prior to any additional sleep surgery after an endotonsillectomy. And the Academy put out this expert consensus statement on pediatric DICE. And not surprisingly, there was consensus that the main indication for DICE in kids is in cases of persistent post-AT OSA. The group identified some points of controversy where there is no consensus and where further research is needed. And the first one was that there's really no standardized protocol or grading system in children. For my DICE, how I do it protocol, I don't use a headrest or shoulder roll. I like to have a nasal cannula and flexible suction available to use if needed. I like to stand up at the head of the bed to be able to control the airway and manipulate the jaw and head position. I evaluate from the nose to the vocal cords. That way no topical lidocaine is needed, as that can impact airway reflexes, and it avoids laryngospasm. And we also know from studies that the diagnostic yield of tracheal assessment in kids is pretty low unless there's a high index of suspicion for it for some reason. I score each level listed here using the IPSES scale, and that's the International Pediatric Sleep Endoscopy Scale that came out of an IPOG consensus effort to try and merge the 7 published pediatric DICE scoring scales that are out there. The scale includes, I think, all relevant airway levels for kids and allows us to document both degree and pattern and site of obstruction. So I really like it. I recommend it. The second point that the group identified was a lack of consensus for an optimal sedation protocol in kids. And the group recognized that either propofol or dexmedetomidine are reasonable choices, but that the inhalation agents that we use for induction really should be discontinued and breathed off for the diagnostic portion of the study. And I do agree with that due to their impact on airway relaxation and reflexes. At Michigan, I'm actually conducting an NIH-funded randomized control trial comparing obstruction scores and the predictive value of DICE findings in kids who are randomized to receive either propofol or dex as sedation. And we're in our final year of recruitment for the study, so hopefully results to come soon. So although the use of DICE in kids is definitely still evolving, it is really, I think, the best tool that we have currently to gather information on residual sites of obstruction after AT. And the studies that have reported on DICE findings in kids show that the turbinates, adenoids, and the tongue base are common sites of obstruction. And indeed, when a collaborative group of us pooled our post-AT sleep surgery cases, we found that we were most commonly performing revision adenoidectomy, lingual tonsillectomy, inferior turbinate reductions, and then less commonly expansion pharyngoplasty or supraglottoplasty. Data on outcomes of these procedures in children is kind of hard to interpret because each procedure is really difficult to study in isolation because we usually do them in combination, and also just in a heterogeneous population of children by definition. For rates of success, there's really a pretty wide range. Most procedures, I would say, fall right around that 60% mark for those that have decent, a decent amount of data. And that's the success rate we also usually see for sleep surgery in the adult literature. Some studies, like the modified expansion pharyngoplasty or studies of epiglotopexy, report higher rates of success, but that's from pretty limited data. So the last point of controversy that was identified by the consensus group was whether DICE performed at the time of adenotonsillectomy in surgically naive children who are at risk for persistence, changes outcomes or improves outcomes. And there's some of us here in the US trying to answer that question for certain high-risk groups of patients. So the first group is children with Down syndrome, and we're actually actively enrolling for an NIH-funded trial called the TOPS-DS. Michigan is one of 6 sites nationally, and we're comparing adenotonsillectomy versus personalized DICE-assisted surgery for children 2 to 17 years old with Down syndrome who have OSA. And we're obtaining polysomnography and patient-centered outcome measures at baseline and then 6 months after surgery, after randomizing them. And then there's a group of 2 sites, Michigan and Oregon Health Sciences, that's looking at the exact same question, same protocol, but in children with small tonsils. We are also performing hypoglossal nerve stimulation in children with Down syndrome, primarily in the US. Generally, we follow FDA approval criteria. It's not universal, but the criteria are the children have to be age 13 or older with an AHI between 10 and 50 after prior adenotonsillectomy, with an inability to tolerate or having failed CPAP, and they should not have concentric collapse at the palate on DICE. And the early studies in kids show good benefit with an average decrease in AHI of 12.9 and a 12-month response rate of 66%, and definite improvements in quality of life, sleepiness, neurocognition, and behavior. And it's very well tolerated with a mean duration nightly use of 9 hours. So in conclusion, persistent OSA is common in kids, and we should anticipate it and be watchful in high-risk populations. The AHI isn't everything for treatment. That's both pre-tonsillectomy and post-tonsillectomy. Symptoms matter. Medical management certainly has a role, particularly in mild to moderate cases. PAP therapy is always an option, should be encouraged. Adherence strategies can be helpful. DICE is used just as in adults to direct site-specific surgical intervention with good outcomes. But pediatric OSA is an active area of research for our field, and we're excited about what's to come. So thank you.
Thank you, Dr. Kirkham. We'll go ahead and get started with the Q&A session. Thank you for a good group of panelists and a great group of talks. That was really interesting. I will hand it over to Dr. Krishnan to get us started with the Q&A session. And as a reminder, please enter your questions in the Q&A versus the chat section at the bottom of your screen.
Yeah, I think we have about 10 minutes to go ahead. So the first question to the last speaker, at what age we can do palpoplasty in pediatric age group? What's the minimal age you think of? To Erin.
Yeah, I can answer that. I don't know that there's an age cutoff or a lower age limit. I would consider it in children, as early as 2 or 3, just as we do with tonsillectomy, but the indications, have to be carefully considered. And DICE findings matter, and also the child's underlying comorbidities, the risk of VPI and how that will affect certain patients. It's different in a child with cerebral palsy who's nonverbal versus a child who's, school age and going to school.
That is so. And a couple of questions to, I think, Vikas. What about velopharyngeal insufficiency risk and pain management after your palatal surgeries? Could
All
you
right.
just
So about velopharyngeal insufficiency, as long as you do not damage or disturb the levator and the palatal, the tensor palati muscles, levator and the tensor, you do not have to bother about velopharyngeal insufficiency. If somebody uses a cautery or radio frequency on the soft palate, that can cause fibrosis and may lead to impairment of the functions of the levator and the tensor, because they will not be able to lift the palate. So if you're not using the BUVI or radio frequency and do not cause fibrosis on the soft palate, and at the same time do not damage the levator and the tensor palati, there's no question of velopharyngeal insufficiency. A temporary VPI can happen for a couple of weeks because of pain, which is fine, which will settle by itself, but no permanent damage on that. Now the question on pain management, obviously when you are doing a palatal surgery, the patient will have pain of 2 kinds. One is that because of the mucosal damage, and one is because of the cutting or destruction of the muscles. So when you open up the muscles undergo myositis, and when the person swallows, there is a very significant pain. So obviously you have to be gentle in your cutting of the muscles, and do not use cautery, do not use radio frequency. That pain has to be controlled by giving some strong painkillers. But the other pain, which is because of the mucosal injury, can be taken care of very well by the standard gargles of Lidocam. The local anesthetic gargles can take care of the mucosal pain, which is not very severe but is persistent. And the severe pain is because of the muscle inflammation, which can be controlled by a very careful surgery and damaging the muscles the least.
Yeah, just to add on, how do you manage those patients who had developed temporary velopharyngeal insufficiency for a couple of weeks still?
So you do not have to do, just reassure that because the muscles are not damaged, the VPI is not going to persist. Take care of the pain. And as I showed, the minimally invasive surgeries that we do today, actually the pain is never so much that you will have a VPI. By evening, every patient is on cold and liquid diet like an ice cream. So it's not that painful. And you can put a patch. The the buprenorphine patch helps too. Yeah.
Okay. Can we have Sukhvinder online to have a couple of questions?
Yes, sir.
Yeah. Can you just narrate about the age criteria for your various procedures? There is a question on that about DOM or SAPE, SAME. So what is the age criteria, lowest age criteria, and how do you...
Sir,
when do you expect us to refer the patient? The question is like that.
See, maxillary expansions, we can start, as the previous speaker also told, that you can start even at the age of 4 years. So from 4 years till 12 years, when the maxillary sutures are not fused, at that time it is a non-surgical expansion. Then comes the 12 to 16 years of age group. In this age group, you need to take a CBCT scan to check how the circummaxillary sutures are fused. So accordingly, you take a decision whether you are going to do a dome or a SARMI. So usually 12 to 16 years, dome procedure works very well. And when there are male patients who are above 30 or above 40 years of age group, those patients are well treated by SARMI, surgically assisted rapid maxillary expansion, because there the suture fusion have very heavy interdigitation. So in those cases, we do the SARMI.
Okay, so well said.
Great. It looks like we have a few questions for Dr. Kirkham also. One is for pediatric patients, do you prefer tonsillectomy or tonsillotomy? I know we didn't talk much about tonsils because we talked once you'd already taken the tonsils out, but if you could comment on that for our audience.
Well, I am admittedly biased because I see so many of our patients who have persistent OSA. So I do a completion tonsillectomy. Most of our group at Michigan does a complete tonsillectomy. We have a couple of surgeons who recently joined us who are doing tonsillotomies. So, and I know that the rates of regrowth, aren't super high. But that's my personal preference and bias, I would say.
Okay, great. And there are a few questions about palatoplasty in children, like what techniques you use and what age you'll consider doing more extensive palate surgery.
Yeah, I basically use a modified expansion pharyngoplasty technique where I use sometimes some tissue rearrangement to pull the posterior pillars forward, but primarily rely on sutures that are buried, in the palatal muscle to pull the palate anterolaterally off the back wall. And I'm happy to receive, emails and share more about specific techniques at any point. Happy to receive that.
And what
Okay.
age, like, how young will you do palate surgery?
Yeah, I mean, honestly, as young as like two, maybe even 3-4-year-olds in the select patient, much more likely to do the surgery in a younger hypotonic nonverbal child whose palate is, really a big part of their OSA than in a child who's, school age, typically developing verbal. And yeah, so I'm a little bit more cautious and careful about VPI risk. It just depends on the patient.
Sorry. How commonly do you perform terminoplasty in pediatric age group?
It's pretty common. I mean, and I find I'm doing it more and more in practice.
Okay.
Christina Baldassari is a pediatric otolaryngologist in Virginia who has studied and performs a lot of turbinate surgery in kids. And we're actually putting in for a grant to try to compare adenotonsillectomy with turbinoplasty in children, for whom it may be indicated. So we might get some funding to look at that specific question to see if we need to be thinking about turbinates up front a little bit more commonly. So yeah, I do it a fair amount.
Do you put all these patients with nasal sprays, corticosteroid nasal sprays, and montelukast in the post-op? Or how is your protocol after the surgery? Medical
No,
management.
I don't necessarily put all my patients on montelukast or nasal steroids. I put patients on nasal steroids if I think it's indicated because they have turbinate hypertrophy or allergic rhinitis symptoms. But I don't expect those to be treating their OSA necessarily. We consider the combination of the two in select patients that come back to see us after adenotonsillectomy who have proven symptomatic OSA that's persistent. That's when I will use it.
Vijay, can I add something here?
Yes.
So in my practice, I use cone beam CT scan for kids, and we decide what is the volume of bone in the turbinates and what is the volume of the soft tissue in the turbinates. If the volume of the bone is very high, then there's no point putting them on intranasal corticosteroids because it's not going to work. And in those cases, we do turbinoplasty and use the sonopet or the piezoelectric to remove the bone from the inferior or the middle turbinates of the kids. So as Erin rightly said, the incidence of turbinoplasty in my practice has also been increasing more and more by the day. It's a very
But the most
gratifying
difficult
thing.
part, sorry, the most difficult part I would feel is how do you clean the nose, the post-operative follow-up?
Yeah, so
for kids.
very good question, because if you have only taken out the bone with the piezoelectric and you have protected the medial mucosa, there's absolutely no crusting. For the packing, if you use the rapid rhino, which is the carboxymethyl cellulose coated pack, there's absolutely no incidence of synechia formation or anything like that. So with the advent of the new packing material, the operating material, the nose surgery is becoming very, very, sophisticated.
Short answer is we don't clean the nose in kids the way that you would in an adult sinus or turbinate patient. Yeah, because the technique generally spares the mucosa, and so you're not getting a lot of crusting. And I would just say that, like, here in the States, we're a little, we just wouldn't have the resources and probably the buy-in to expose kids to even the little bit of radiation consistently that would come with cone beam CT. So, a lot of times, that's really interesting, and it makes total sense to use the imaging to guide your management. But honestly, we usually end up just doing an empiric trial of the nasal steroid to see if it's beneficial. And it's pretty inexpensive. It's pretty low risk. All it takes is a few months of time and a follow-up visit to determine if it was working. And then from there, we generally would move forward with surgery.
True. So do you put all your patients for myofunctional therapy post adenotonsillectomy? Children, especially, I'm asking for.
No, I don't. No.
So what is any specific criteria that this group of patients you ask them to do myofunctional therapy, or?
So I will absolutely, I will tell you what I know and what I don't know. I don't know a lot about myofunctional therapy. And so if patients sometimes pursue that independently as treatment, and, I'm in full support of whatever you want to try. But I don't know a whole lot about it. And I don't know that we have a big evidence base for it at this point. Not to say that it can't benefit some people. I'm sure that it does. But I just don't routinely, work with a myofunctional therapist.
I think this will be the last question to Sukhvinder. And what is your point of view on this myofunctional therapy for the patients who underwent SARPE or MARPE or a dome procedures?
Sir, I am not very well versed with myofunctional therapy, because myofunctional therapy and surgery, post-surgery myofunctional therapy is an adjunct to it, but it is never a replacement for surgery. When there is a clear-cut short maxilla, narrow maxilla, even if you try to do myofunctional therapy, it might not work. So we need to put it hand in hand, and we need to select our case very wisely, that when we are doing a surgical expansion, I don't think myofunctional therapy has a major role to play in case of surgical patient.
Fine.
Okay, great. Thank you. We have so many questions. I love the engagement. I think there are like 23 questions. We've answered 20. We'll try to get to the 23 in the next few minutes. Thank you all.
I'm trying to type the answer.
I know. Thank you. Type as quickly as you can. No, I'm just kidding. So thank you to our wonderful panelists. Those were just excellent presentations. Clearly the audience is engaged and interested given how many questions we're receiving. So thank you so much. Thank you also to the sponsors, the Academy, the ISSS, and the AAO-HNS, as well as Inspire Medical. I will hand things over to Dr. Cerna, who's going to do a quick wrap up, and then we will conclude.
Thank you so much. The lectures were truly fantastic. I think all of us continue to learn from each other. So thank you for sharing. A lot of research, a lot of new ideas are coming from all over the world. So I think that's why it's so wonderful to have this collaborative lectures and global grand rounds, because again, it's really truly important to learn what we are doing in various parts of the world, in the fields, and you can see there's a lot of new ideas and the new innovation is happening. So I want to announce our next global grand rounds. They're going to be dedicated to learning about novel technologies and treatment strategies for head and neck cancer, from robotic to immunotherapy. It's going to be on February 28th next year, the same time. The registration link is going to come soon, so save the date, and we hope to see you all there. I also want to bring to your attention that the next American Academy of Otolaryngology and Head and Neck Surgery meeting is going to be in Los Angeles, California. It's in October 17th through 20th. Registration is going to open in May of 2026. The call for science is very important. It opens December 1st, and the submissions are accepted through January 26th. So if you would like to share your knowledge, expertise at the annual meeting, please make sure to submit your proposal by the deadline. As far as our international members, we have wonderful opportunities for all of you. Being part of the international physician member of the American Academy of Otolaryngology, it gives you opportunities to get engaged. We have a lot of educational opportunities, resources available. One of the new things that we added is a otolaryngology patient scenario series, where you can do case-based courses that are covering all subspecialty areas. And for international physician members, those are free, so please take advantage of that. Again, Global Network is one of the core pillars of our academy, and we do connect a lot of otolaryngology physicians across the world, so please get involved. We also are looking forward to seeing you at the annual meetings. We do provide grant and support for international physicians, especially for travel scholarships and research funding. Please take advantage of joining our global community at the Academy of Otolaryngology and Head and Neck Surgery. We are soliciting applications for American Academy of Otolaryngology Head and Neck Surgery committees. The applications are being accepted through January 5th of 2026. It's an opportunity for international members to influence our specialty. We are looking for your opinions, for your voice, because it helps us shape the policies, education, and clinical care. Opportunity to be highlighted as a leader in the field and collaborate with other leaders across the specialty. Again, international members' perspective really matters, so please consider joining our committees, and please get involved. Sorry. And with that, I would like to, again, thank all of our participants, and thank all of our panelists and sponsors. And if you have any questions, please contact international@entnet.org. And please keep in mind that all of the recordings are going to be available, and you will receive, all the attendees, all the participants will receive the certificates, link to the certificates that could be downloaded, and also links to the recorded session. And that will be emailed to you the first week of December. So please look out for that. And once again, thank you so much.